Now I'd like to go ahead and introduce our next speaker. It is Patricia Schumacher from the CDC. Ms. Schumacher assumed the position of Branch Chief for the Program Implementation Branch in CDC's Division of Diabetes Translation in June of 2016. In this role, she leads a team of about 35 staff, contractors, and fellows working with state, local, and territorial public health departments, tribes, national organizations, and numerous other partners to eliminate the preventable burdens of diabetes. Ms. Schumacher is a registered dietitian and holds a Master's of Science in Nutrition and Institutional Administration. Please help me in welcoming our next speaker, Ms. Schumacher.
All right, well, thank you so much. Very glad to be here virtually this morning to talk about the diabetes prevention and control landscape across the U.S. Certainly a lot going on, a lot happening in the Midwest as well as all over the country. So just a little bit about what I'm going to cover this morning. I will talk a little bit about current and future trends. CDC, we're CDC, and so we always talk a little bit about the data and what's going on there. I'm going to spend the most of my time talking about our current priorities and kind of where we're headed as a nation with diabetes prevention and control and through our efforts here at CDC. And we'll also touch on some of the resources that we have either currently available or coming down the pike. And then finally, opportunities for collaboration, because that's key in everything that we do in public health. And we try to do that across a variety of sectors. So starting off with the numbers, as we often do, and we use this slide a lot because it really gives a nice visual depiction of our public health challenge in the U.S. with diabetes. And if you look at the little iceberg in the corner of the slide, we know we've got about 29 million Americans with diabetes currently. That's a huge number, and it oftentimes, for those of us working in diabetes, self-management and control, feels overwhelming. But when we look at what's below the tip of the iceberg, so to speak, what's below the surface, we've got another 86 million U.S. adults with prediabetes. So these are the folks that are at very high risk for developing type 2 diabetes. Their blood sugar levels are higher than normal, not high enough to be diagnostic for diabetes, but higher than what they should be. So we know that they're on a trajectory. Now, across that 86 million is a huge number, and we know across that group, there are different levels of risk, certainly. But the important takeaway is those folks are at higher risk, not only for type 2 diabetes, but also for heart disease and stroke. We really do have an obligation in public health to empower those folks by raising their awareness of the risk, what it means for them, and then also how to protect their health. So I think the message here is that we have to really divide our efforts and our interventions across both areas. Certainly we have to focus on people who have diabetes and try to keep them in good health, as well as preventing all of those people below the surface of the water from going on to develop type 2 diabetes. So looking a little bit at trends and incidence and prevalence, and this is from a paper that we just released earlier in 2016. And as you can see, it's an interesting trend, both for incidence, which is new cases of diabetes, and then prevalence, looking across the burden on the population. You can see for decades, couple decades now, the increase, the spike, that was pretty dramatic. And then over the last few years, we've kind of seen a leveling off and a little bit of a decreasing. So very interesting findings. We don't know if that's going to continue. We can speculate maybe as to why some of that's happening. Certainly, some of our treatment, control, and prevention efforts have improved. But the question, I think, for all of us is, will that continue, or is that a little bit of an anomaly? And that we can't answer. But I think even though the news is very encouraging, it really underscores the importance of now more than ever, we really need to escalate our efforts in diabetes prevention so we can ensure that that trend, that downward trend, does continue. I think that's something we all want to see. So here too, we've got some good news, and these are complications of diabetes. And these rates, as you can see, have also been leveling off and going down. So as a nation, we've been making progress in addressing diabetes complications due to a variety of things: better care, better medications, better education, and so forth. So I think we can all take a little bit of credit for this. We can all pat ourselves on the back. But again, we know if we don't prevent those new cases, we're going to quickly undermine any gains that we've made, because the denominator will be essentially flooded by new cases of diabetes coming into the system. So I think the message in all of these slides, again, is that we have to focus our efforts in both areas, both treating diabetes, as we're very good at doing, and also in prevention, which is a bit of a newer area for us. So looking at CDC and where we invest, and this is really a broad view at our center level. We are in the Division of Diabetes Translation. We're located in CDC's National Center for Chronic Disease Prevention and Health Promotion. And we are actually one of 8 divisions in that center. So across all of our portfolio of work in the center, we do focus in both areas, in both chronic disease control as well as prevention. And we work across 4 domains. These 4 domains really form the framework for all of our work, kind of uniting us all in our center around chronic disease prevention and control. And we all across our divisions invest in each of these domains. So I'll just touch on them briefly. The first one is epidemiology and surveillance. So we all know in public health that's a key part of what we do. We've got to look at the data, both monitoring the data, looking at trends, looking at what's happening in our target populations, and then using that data to inform our interventions, to inform our decisions. That's just critical. Our second domain is environmental approaches. So these are the things that we do to improve the social and the physical environments, to make healthy choices the easy choice. For more Americans. So these are things like working in communities to ensure safe places to exercise, creating healthy food options, policies that make improve the quality of food selections in schools and work sites in a variety of settings. So things that we can do at the policy systems and environmental level to make healthy choices easier. Domain 3 really addresses the healthcare, the clinical environment, improving quality of care, improving the way that we work clinically to deliver the best care that we can, both for prevention and control. And finally, domain 4, which is community programs linked to clinical services. So that's that community clinical linkage piece where, you know, this has been a big area over the last few years for us, because we know that even though when people are in the clinical environment, they're usually there for a very short period of time. And there are a lot of services and resources available outside of the clinical setting that contribute to chronic disease prevention and health. So that clinical community linkage is important because it's linking those patients to those services that exist oftentimes at the community level. So this just takes another look at some of our strategies across those 4 domains. And again, across the center, we all invest slightly differently in terms of these 4 domains and our interventions and strategies that we support. Here in the Diabetes Division, the Division of Diabetes Translation, we invest most heavily in those bottom 2 domains. So health system interventions and community clinical linkages. And we also, of course, part of our role as an agency here at CDC is we do maintain the U.S. diabetes surveillance system. So surveillance is important for us as well. Data are important, EPI is important. But in terms of our programmatic interventions, we're really focused in those two bottom domains. And really primarily over the last few years in the community clinical linkage domain. I think that's where we feel we've got very strong science that tells us we've got effective interventions here. So if we can scale those interventions, we know that they work, we know that they produce outcomes. So our goal in public health is really getting those out there, making them more accessible, more readily available, so that people have access to those programs and services. And that's a large part of what we do in Domain 4. I think it's also important to note here is that, with usually our resources in public health are pretty limited. So we rather than working in a whole bunch of different areas where we're kind of a mile wide and an inch deep, we really try to focus our resources where we invest across the nation in a few key areas. We do that because we have a greater chance than collectively of producing outcomes, really having an impact in those areas. And also, we always use our science to guide us. So we tend to invest more where we have the strongest science that tells us if we do these things, good things will happen. So in Domain 4, we have 4 key interventions in our division that we put a lot of effort behind. So those are increasing access, participation, and reimbursement for DSME, Diabetes Self-Management Education. I'm going to talk more about that. Our second strategy revolves around the National Diabetes Prevention Program. So that's increasing prediabetes awareness, and it's really scaling up and sustaining the program across the U.S. So those top 2 interventions I will really focus on during the majority of my presentation this morning. But just so you're aware, and some of the state health departments that are participating on the call this morning are also working in the area of extending and expanding our use of healthcare extenders. So increased use of community health workers, pharmacists, both in the clinical setting as well as in the community in support of diabetes self-management and prevention. And then also increasing use of chronic disease self-management programs. Those programs are important for support no matter what chronic disease you have, that support function is critical. So let's go back to those top 2 interventions, Diabetes Self-Management Education and the National Diabetes Prevention Program. And I'll talk a little bit more about what CDC is doing in both of these areas, starting with DSME. And I think everybody participating this morning is very familiar with the definition of Diabetes Self-Management Education. But it's really, really critical, not that it isn't for any chronic disease, but especially with diabetes. There's a lot to know, and there's really a lot of things that a person with diabetes really needs to manage on a day-to-day basis, things that they have to do every day to manage their condition and to protect their health. So it's a very complex disease, and education becomes so critical in being able to really keep your blood sugars where they need to be, maintain your health over time. And we know that diabetes self-management education also gives us the foundation to help people with diabetes kind of navigate their way through all those complex health decisions that they have to make every day. We know through the literature that it's been associated with reduced A1C, has an impact on hospitalizations and ER visits, improved wound healing, and a number of other areas as well. We have a number of economic studies out there that have shown the benefits and the cost savings associated with DSME, that reduction in A1C, those healthcare costs, and so forth. That's really, really critical in making the business case for why we do that. So we refer to those studies quite often. And why do we care about all of this? Well, certainly A1C is important in addition to a number of other factors that we manage in diabetes. But when A1C levels are high, we know that even a small reduction makes a huge difference in health and prevention. And this slide kind of provides an overview of that. A 21% decrease in diabetes-related deaths, a 14% decrease in heart attacks, and a 37% decrease in microvascular complications. And that's just for a 1% reduction in A1C levels, so when they are elevated. So that's critical. So as an agency, where do we invest in DSME? So we fund all 50 states through cooperative agreements. We support all 50 state health departments to do work in a variety of areas, but DSME is a key area that we invest in. And again, we're funding those state health departments to increase access to DSME programs, increase participation in DSME, mainly through referrals, and then also addressing reimbursement, primarily through the Medicaid program. We at CDC really place emphasis on those recognized and accredited DSME programs, recognized by the American Diabetes Association or accredited by the American Association of Diabetes Educators. Why do we do that? Well, number one, those programs are connected to a set of national quality standards that they have to meet. So that ensures that those programs are being delivered with fidelity. They're following a curriculum. They're ensuring that staff and educators are trained and so forth. We know those recognized and accredited programs, again, in large part because of those quality standards, are reimbursed by Medicare, by many private health plans, and then again by some state Medicaid programs. And we're working to increase those numbers. So that ultimately helps, doesn't ensure, but helps to sustain those programs over time. So through our cooperative agreements, we've got 50 states, plus the District of Columbia, working to increase participation in DSME, so driving referrals to programs. And then we have 45 states, all but just a few, who have selected this area really to go deeper in and to increase access and reimbursement and to move those numbers even further. And that includes all 4 of your states on the call today. So what are some of the things from a public health perspective that state health departments are doing to support DSME? Because the states, of course, are not the ones on the ground delivering DSME programs in communities. So what are they doing? Well, through the course of this 5-year cooperative agreement, a lot of states started early on by kind of looking at the landscape in their state, conducting assessments, trying to determine where are the available programs, where are they located, where do we have gaps, what are those programs' capacity, utilization patterns, reimbursement and coverage, what's the picture look like in our state, where are referrals happening and not happening, what are we doing around promoting DSME, and so forth. What are other facilitators and barriers to access happening at the local level? So based on that initial assessment of where are the gaps, where are the needs, they've done a variety of things. Some states have really worked with a number of organizations, FQHCs, pharmacies, local health departments, many other kinds of groups in establishing new DSME programs and in getting those programs recognized or accredited. They've also been pursuing some policy work with their sister agencies on the Medicaid side to expand Medicaid reimbursement for DSME in the states that don't currently have it. They're training and educating healthcare providers on the benefits of DSME and how to refer. Why should we care about this? Why is this important for our patients with type 2 diabetes, type 1 diabetes? When do we refer? At what course along the progression of the disease, all the way from initial diagnosis through managing a patient long-term, when is it important to refer to DSME? And then developing referral mechanisms, building and helping to automate referrals, in some cases using the EHR, in other cases using other means, online data portals, and other mechanisms to promote referrals and to ensure that it's kind of built into the system. We too have a number of resources coming out of CDC to support both the states as well as others who are doing this work in DSME. We just came out this past year with a new series called Emerging Practices in Diabetes. And this is really taking some of those valuable lessons learned from our state health departments as well as our other partners and putting them out there so that others who are trying to do this same work can benefit from hearing more about the approaches that others have taken, who they were working with, how they did it, essentially. So in DSME, we have 5 new emerging practices that came out over the past few months. The first of those addresses referrals. So different ways, different mechanisms and approaches that have been taken in different states to really drive referrals to DSME. Approaches to increasing access and participation in those local programs. Approaches to accreditation and recognition. We have a number of states that have done some work with the Stanford Diabetes Self-Management Program, and so efforts to basically take those programs that often start as a peer-led sort of program and then transitioning them into programs that can actually achieve ADA recognition or AADE accreditation. We have some emerging practices around gaining Medicaid coverage for DSME, several states that have done that successfully and how they did that. And then finally, engaging community health workers in DSME programs. If you haven't seen those emerging practice documents, the link is on the slide. I would encourage you to take a look. And another resource that this is brand new. This is in development currently. So it won't be actually out for another year or so. But at the national level, we are developing a DSME. We're referring to it as a toolkit, although it's really much more than that. But a toolkit and a training series on DSME to really provide a one-stop shop for a variety of tools and resources supporting DSME. We know there's good materials out there around these things, but unfortunately, nothing that's pulled all together in one place. And we find after years of doing this, there's a big need for that. We don't want to have all 50 states developing PowerPoint presentations on the benefits of DSME, making the business case, all of these things. We want to be able to consolidate some of those tools and resources and have them available to anyone who needs them to make that case. So some of what's going into this toolkit, as I said, sort of the background of DSME, what are the benefits, what is the scientific evidence, what do the economic studies show in terms of cost savings and so forth. Why should we promote this? Why is this important? The role of the national standards for diabetes self-management education and support. What is the accreditation and recognition process all about? How do DSME referrals happen? How are they coded? How do you bill for DSME? How do you staff and deliver DSME? Marketing and promotion and tools that you can use to do that and to get the word out in your community. So ultimately, we feel like this can be useful for not only states, but programs that are delivering DSME, diabetes educators, other healthcare professionals that work with diabetes patients and are trying to promote or stand up diabetes self-management education programs. So that'll be coming later in 2018. And I'm going to switch gears a little bit now over to the prevention side of our work and the National Diabetes Prevention Program. Because remember, we're dealing with that two-sided coin, both self-management and control as well as prevention. And hopefully everybody participating this morning, I hope that there isn't even one person who hasn't heard about the National DPP at this point in time, because if so, then we're not doing our job in promoting this program as we should be. So hopefully this is old news for everyone. But in case it's not, I will give you just a little bit of background on the National DPP. This program in the larger scheme of things is fairly new, but it was based on a long history of evidence, starting with the original DPP, Diabetes Prevention Program research study done back in the late 90s. I think, again, most people are familiar with the DPP, but basically what it did, it was a very large trial, divided participants into 3 groups who were exposed to a very intensive lifestyle change intervention, a second group who took metformin, and then received a little bit of counseling, and then finally a placebo group. And overwhelmingly, the findings showed that the lifestyle change intervention group had the best results. They actually reduced the risk of developing diabetes by 58%, which was very dramatic. That rate even went up higher in those 60 and older to 71%. And this has been studied extensively, is still being studied through the Diabetes Prevention Program Outcome Study. So they're continuing to follow a subset of that group. So at the 10-year mark, even after 10 years, those in that original lifestyle change group were still 33% less likely to develop diabetes, and they now have 15-year results out. So very, very encouraging over the long term. And then, of course, this study was a clinical trial, so it was done in a controlled setting. It was very costly. It involved counseling and intensive work with healthcare professionals across a variety of different areas of expertise. So over the last decade or so, a variety of translation studies followed the DPP, basically to see, can we take this and all these great results that we got through this trial and put it into the real world, into community settings, make it accessible and available to larger numbers of people, and do it in a way that's cost effective. So that was our goal. And out of that work, the National DPP was born out of that Diabetes Prevention Act that Sherry mentioned earlier, around 2000, late 2009, early 2010. And then just recently, over the last couple of years, we've had additional recommendations that have been studied and have been released by a number of groups, the U.S. Preventive Services Task Force, the Community Guide, and others, that have kind of given additional weight to the importance of lifestyle change intervention in the prevention of type 2 diabetes. So this highlights a few of those reviews and recommendations. I'll call your attention to a couple of these. The first is the Community Guide review that looked at diabetes prevention, combined diet and physical activity programs to prevent type 2 diabetes. This was done back in 2014. Strongly recommended these programs for people at increased risk, named the National DPP and the Lifestyle Change Intervention supported through the National DPP specifically. Also, if you look right below that on the slide, the U.S. Preventive Services Task Force, also in 2014, came out with a recommendation on healthful diet and physical activity for cardiovascular disease prevention. Again, recommended for those adults who are overweight and obese and had additional CVD risk factors to intensive behavioral counseling. Again, mentioned the National DPP. So we've had more and more of these recommendations, all of these groups and organizations that have been coming out with recommendations, kind of further reinforcing the importance and the need to do this. So we have a lot of evidence for the program and for this work. And we're at a point now where our goal is getting it out there. We've studied it intensively. A number of groups have studied it. We've got good results. We need to spread and scale up and sustain. So that brings us to where we are today, and that's the National Diabetes Prevention Program. So at the core of this program, and I think you all know this, is a year-long lifestyle change program. This is for people at high risk for type 2 diabetes. So these are people with prediabetes or at very high risk. The lifestyle change program is conducted in a couple of phases during the course of a year. So during the first phase, that consists of 16 sessions that are weekly. Participants meet usually in small groups. They meet with a trained lifestyle coach. And the goal is, through healthy eating and physical activity, the goal is to achieve that 5 to 7% weight loss that was shown in the original DPP research study. which resulted in that 58% decreased risk for developing type 2 diabetes. So this is modeled after that original study, just taking it out of the science environment and putting it into the real world, into communities, into faith-based organizations, community health centers, YMCAs, and other groups to deliver this and make it accessible for folks. The national DPP as a whole, which CDC administers, is really the larger collaborative. So it's a cross-sectoral group looking at a variety of public and private partnerships, because there's no one entity that can do this alone. We are dependent on community-based organizations, on insurers, on employers, on the healthcare sector, on public health, a variety of different groups to basically take ownership in this and to together collectively work to spread it, sustain it, scale it across the U.S. So that's been our goal since 2010. We've made, in a relatively short amount of time, quite a bit of progress. And I will touch on a little bit on the economic impact, and we'll come back to this. But again, we know that when people develop diabetes, their healthcare expenses go up, increase dramatically. That's been studied quite a bit. If we can prevent that from happening or even delay it from happening, that's absolutely key. So when you look at, and this slide just kind of shows the cost of diabetes treatment, averaged at over $8,000 per individual when they're first diagnosed, and then you can see the cost there for the first 3 years with someone with newly diagnosed diabetes. Compared to the lifestyle change intervention, which depending on the mode of delivery averages out at about $500 per participant. So you can kind of see the balance there. And we'll touch on this also in a few minutes, but I think you all are aware of the work that's been done with CMS through the Centers for Medicare and Medicaid Innovation. The National DPP's Lifestyle Change Program will become a benefit for Medicare beneficiaries beginning in January of 2018. And as part of that, leading up to that, the YMCA, the USA, was awarded funding through CMMI to study this in Medicare beneficiaries, to take this program in 17 states to Medicare beneficiaries and basically make the case for this from a cost savings perspective. They were able to do that through a CMS actuarial analysis. It showed that the YDPP program avoided over $2,000 in healthcare costs over a 15-month period per individual who participated in the program. So very, very strong evidence here making the case again for this from both a quality perspective, quality of care, as well as a cost savings perspective. So let me just briefly touch on some of our goals here with the National DPP, because I know a number of you are involved in one way or another in these goals. So we really work across 4 areas through this program at the national level. We're working to increase the supply of quality programs across the U.S., working to increase demand, because obviously it doesn't do any good to have programs if nobody's in the program. So that's key. Working to increase referrals from healthcare providers and healthcare professionals, and then coverage and reimbursement. So touching on each of those goals, just really briefly. Programs have increased pretty dramatically. We started our recognition program for these programs back in 2012, and you can see the growth over time. We're now at over 1,000 programs across the U.S. We're in all 50 states, as well as Puerto Rico, D.C., the Virgin Islands. Coverage and reimbursement we've been working on, that's absolutely critical. And these things really need to happen in tandem. We have to have an adequate supply of programs. We also have to have a source of reimbursement for those programs so that they can sustain over the long term. So as you can see on the slide, we have over 60 health plans right now that provide some level of coverage for the national DPP. These are in specific markets for specific populations or specific employers. So just because you see a health plan up on the slide doesn't mean that's universal coverage. And again, this is just a sampling of some of those plans. Looking in states, we've got 11 states currently that have coverage for their state or public employees. So that's over 3 million lives covered there. And we have 2 states that have coverage for Medicaid beneficiaries. Increasing referrals from healthcare providers. This is really important. Even though a referral is not required, it's still critical. We know that if your doctor tells you to do something, there's a greater chance that most patients are going to take that seriously. And if you could pardon me just for 1 minute, I will, just to get a cough drop here, I'll be right back. Okay, so sorry about that. So this slide just kind of shows a picture of some of where CDC is investing to help increase referrals from healthcare providers. We have a strong partnership with the American Medical Association, doing a number of things there to increase screening, testing, and referrals. Just recently started some work with the American College of Preventive Medicine around the same area, working in different parts of the country to do that. As I mentioned, we fund all of our state grantees across the U.S. to increase prediabetes awareness, to drive traffic to the programs, and also to look at reimbursement and coverage. We're funding some groups also to do some innovative testing on ways to integrate referrals into the healthcare environment. The Y is one of those groups that just started a project recently to explore bidirectional e-referrals. So thinking about how do we connect many of these programs that are based in communities with healthcare environments, because typically there is no way to transfer information back and forth. We're not connected. So how can we use an EHR to do that, to exchange information between a community-based group like a Y to a healthcare environment, so that a physician can make a referral and can also receive information back on their patient and how they're doing in the program. So we're doing some innovative work there. Increasing demand for the program. Well, our participants are growing. You can see the history here beginning in 2015, all the way through this past August. And remember, this is a year-long program. So by the time CDC gets data from a program, a recognized program in our registry, they would have to have delivered the program for a full 12 months. So there is a little bit of a lag time here by the time we get data and can track these trends. But we have, now it's a little bit over 90,000 participants in our registry. And so thinking about those goal areas, I want to touch on a few priorities that relate to those goals. We did some work here at CDC in our branch on a growth plan for the national DPP earlier this year, thinking about how the program is growing, where we expect growth, and what we need to do to support that growth and to sustain it and to continue to grow the program. So those priority areas include our recognition program, which I'll touch on, all of the strategic partnerships that are so key in getting this work done, our efforts to market and promote the program, of course, our science that supports these efforts, and then our training, assistance, and dissemination. So starting with training. We have a number of things, as I mentioned in the DSME area, even more so in the prevention realm, that are either have been developed or are brand new or are coming down the pike. One of those things is a customer service center. We have, as I mentioned, and you just saw in the previous slide, we have over 1,000 organizations in our Diabetes Prevention Recognition Program registry. That number is growing. With Medicare reimbursement looming in the future, we expect that number to continue to grow. So we need to expand our efforts and our capability here at CDC to be able to provide training and support, not only for those organizations, but also for the myriad of other partners who are working in this area, who are either wanting to start new programs, wanting to support to help get those programs reimbursed or covered, variety of areas. So we are starting up a customer service center in 2017 that will help us to do that, will help us to better respond to the organizations in our registry who come in with questions or who have questions about their data, need help in different things, need help around sustainability, are struggling with recruitment, retention, et cetera. We are also working to streamline our DPRP Ask email box, which is our current source for organizations to reach out and ask questions and get technical assistance. And we also hope to link some subject matter experts to this customer service center so that specific groups that need help, if you're an employer and you're trying to start up a program for your employees and you need some guidance in how to do that, can actually reach out to a consultant to help you and to work with you on that. So that's coming later in 2017. We have a variety of other tools and resources that I'll briefly touch on some of those. And then our Prevent T2 curriculum, which is our new curriculum for the lifestyle change intervention, was released last spring. And we'll touch on that as well. Hopefully most of you have seen it. So across some of our new tools and resources and development, we have a lot of organizations that are interested and want to find out more about the Diabetes Prevention Recognition Program, what's involved in CDC recognition, what do I need to do to apply, what do I need to do to be successful. We get a lot of inquiries on this, way more than we can handle on an individual basis. So we're developing some tools, some online videos that will be available and accessible to anybody who's interested to learn more about this as you're considering making the decision to start up a program. What's involved in that? We have some toolkits in development on working with high-risk populations for those programs at community levels who are working with a low socioeconomic, a Medicaid population, certain vulnerable groups that where it might be more challenging to deliver the program, more challenging around recruitment, keeping folks in the program and so forth. Some guidance for those groups on working with those high-risk, vulnerable populations. We have some toolkits in development specifically for working with the Medicaid population as well as with private insurers. We'll be developing some videos for our CDC recognized organizations to give them some additional technical assistance. Some of those involve assessing your capacity to do this work, learning this and understanding the national standards, how do we submit data to CDC, and so forth. Training for lifestyle coaches. We do have a requirement that lifestyle coaches be trained. That's really a responsibility of the organization delivering the lifestyle change intervention. We have a variety of organizations out there across the U.S. who offer training programs for those lifestyle coaches. But we know and we've learned through a few years of doing this now that the role that lifestyle coach plays is just so critical. That person really is a critical linchpin in all of this, in both keeping people in the program, keeping people motivated, kind of serving as a connector, has to be an excellent facilitator, able to engage folks. That takes a lot of training and experience. So we do want to offer, in addition to the basic training for lifestyle coaches, we do want to offer some supplemental training to help continue to advance and build their skills. And then finally, as I mentioned, after a few years of doing this across a number of different groups who have been running these programs, a lot of lessons learned coming from the field. and from programs that have been successful in how have we done this, how have we approached it, how have we overcome some of those challenges. So we are trying now to compile some of that in a way that others can use it and benefit from it as well. We also, going back to that emerging practice series that I mentioned earlier, we also have, as part of that, a number of these emerging practices that deal with the national DPP and diabetes prevention. For states, we have a document that highlights some of the stories from states that were able to get the program as a covered benefit for state employees and how they did that. That referral document that I mentioned earlier, promoting referrals both to DSME and or to CDC recognized diabetes prevention program sites. Approaches for marketing the program, both the populations at risk, those people with prediabetes or at high risk, as well as the healthcare provider community. And then approaches to employer coverage for the national DPP. This is a really interesting one. We have 5 very large employers across sectors, including groups like Costco and Bath Iron Works and a large international law firm, a university, and so forth, who tell their stories. These are groups that are actually offering the program for their employees as either a wellness benefit or a covered health benefit. So they tell their stories in this document about how they did that and how they went through the process and what kind of was instrumental in helping them make the decision to do that. So these are all kind of a wealth of resources. So please, if you haven't had a chance to look at these, definitely take advantage of that. We also have a couple of economic and burden toolkits that are coming also in 2017. These will be online toolkits. The first one really helps you assess what's the burden of diabetes in your state and how that translates to cost. So at a state level, it will give you information on state-specific estimates on the health burden of diabetes. So prevalence of diabetes by age and by sex, diabetes attributable cases of coronary heart disease, stroke, blindness, all those complications. Diabetes attributable deaths across the board, aggregated. Healthy years of life lost, as well as quality adjusted life years lost due to diabetes. And then on the flip side of that, trying to then again kind of link that to cost. So looking at diabetes attributable medical costs, as well as diabetes attributable productivity lost. So for an employer group and for others who care about this, looking at things like the cost of absence due to diabetes, reduced productivity at work, and so forth. This toolkit will also have the capability, if specific groups using it have their own data on their own target population, for example, an insurer, an employer who has data that they want to input as opposed to using the default values in the toolkit, they will also be able to do that to get a better picture of what's going on, the burden of diabetes in their own population. And then a companion to that is our economic calculator. The target audience here is state health departments, insurers, and employers. This will focus primarily on the economic side with the National Diabetes Prevention Program Lifestyle Change Intervention. It's going to give you specific estimates of program costs and cost effectiveness or cost benefit, looking at both a 5-year time frame as well as a 10-year horizon. So it'll give you a snapshot of what's the total cost depending on the parameters that you input of delivering the program, looking at the health benefit that's potential to gain through the program, the cost effectiveness, and then if there is a cost savings, we'll calculate that as well. And again, we'll give users the option to input their own data if they have it. Our new Prevent T2 curriculum for the program, this is the Lifestyle Change Program. This is one of 2 curricula that are up on the website. There are many others that CDC reviews and approves that different organizations or groups have developed and tailored for different populations, but they're all based on the same content. Prevent T2, when we redesigned this and released it earlier this spring, really based on a lot of lessons learned from delivering the program over a number of years, reduced the literacy level. incorporated a lot more graphics, made a lot more handouts and other resources available for the lifestyle change coaches working on the ground. In addition, we developed a Spanish version of the curriculum for Prevent T2. And this was more than just a cultural translation. It was actually a separate version created in Spanish using a Spanish-speaking audience, doing focus groups and so forth, to make sure that it was culturally relevant. And so both of those are available on our website. So that's just a smattering of some of the tools and resources that we have available or that are coming and may be of interest to you. So touching just briefly on our recognition program, if you're involved in the National DPP at all, or you may be running a program in your community, you know that the CDC Recognition Program is key. Similar to, as I mentioned with DSME, ADA's role in recognition and AADE's role in accreditation, this is a similar role that we play with regard to diabetes prevention. It's really a quality assurance role. So across all of these programs, and as we said, over 1,000 different groups that are delivering classes in communities, we want a way to ensure that these groups are not only producing outcomes, but also delivering with fidelity, because again, this whole program is tied to that original DPP science and the findings from that. So we want to ensure through our quality assurance arm that the programs delivering on the ground are getting those same results and are delivering the program with quality. So as part of the recognition program, we do maintain those national quality standards. They're revised every 3 years, getting ready to go through another revision process. So we'll have a new set of standards, slightly revised, coming out in 2018. We maintain the registry of organizations, as I mentioned. And we also have to have, as you can imagine, a system in place to accept data from that 1,000+ number of organizations out there. So we do that electronically. We're looking at that data system as part of our growth plan and looking at enhancements that need to be done. You know, how can we continue to grow and meet the needs of increasing demand? Here's just a snapshot from our website, of our program locator website. You can download both a complete listing of all of the CDC recognized orgs across the country, or you can select from a list. We also have a map available where you can click on your state and you can see a list of publicly available programs that participants can access. So anyone can go on this website. It's updated every single day. It is based only on our recognized programs, and in terms of the class information, it's only as current, unfortunately, as what the organizations tell us. So some groups are very good about telling us when they're starting classes, where those classes will be. Other groups have chosen not to do that, but where that's available, we do include that in our listing and in our program locator map. A lot of lessons learned coming from the field and from the initial 2-3 years of doing this program, running the program successfully for a year or more in communities. One of the key lessons learned, and we'll have a lot more coming out, as I mentioned, later in the year, of some of these lessons learned that others could take advantage of. But I will highlight one thing that's very, very important if you are running a program. And we've seen this across all of our data across racial and ethnic, different racial and ethnic groups, different age ranges and so forth, males, females, been a uniform trend. And that trend is that intensity and duration matter. So those programs that are able to keep participants in, able to keep participants going over not only for the full year, but also to a greater number of classes during that year's time. That really does translate to outcomes. And the main outcome, again, that we're tracking is that 5 to 7% weight loss. And you can kind of see a snapshot of that here. Programs that have participants attending 17 or more sessions tend to really show much better weight loss than those with less than that. So we are investing a lot in looking at ways to support not only recruitment, but also retention in programs, because we're learning, again, more and more that that's absolutely key. And so moving into partnerships. As I mentioned earlier, the National DPP is not about CDC per se, it's really a collective. It takes a village to do this. And without involvement from all these different sectors, we really cannot be successful, and we will never be able to scale and sustain this program across the nation, which is our goal. So your involvement and all of your organization's involvement in this is really important. We work with a variety of partners in a variety of different ways. Some of those are funded partners. So we do have, as I mentioned previously, several cooperative agreements that we fund. Some of those fund state health departments, national organizations, other groups. These are three of those that focus on the national DPP. The first, and we use, just to shorten the name a little bit, all of these have very long names, so we tend to use the abbreviated numbers and identify them that way. So the first one, which we refer to as 1212, that cooperative agreement is in its 5th year. It basically funds 6 national organizations. The goal of those groups is to increase the number of programs. So they were in a startup mode, starting new programs through their affiliates across the country, starting new programs, and then also working on not only referrals, but then also to expand coverage so that those programs, once they're established, can sustain themselves long term. So those 6 organizations have been really critical, and they are a lot of the ones who have generated so many of those early lessons learned from their work in doing this on the ground. Those groups include the National Association for Chronic Disease Directors, American Association of Diabetes Educators, America's Health Insurance Plans, Optum, and AADE, the American Association of Diabetes Educators, and then lastly, the Y of the USA. Under 1305 and 1422, we fund state health departments. 1305 funds all 50 states and DC. The goal is to raise awareness of prediabetes, increase referrals, and work with state employee benefit plans and Medicaid to increase coverage. Under 1422, we're more focused. We fund 17 states and 4 large cities that include New York, Philadelphia, LA, and San Diego to expand on some of the work started in the other 2 cooperative agreements, but really to focus on vulnerable high-risk populations in different areas of their states. So that work is ongoing. Part of what we've been able to do with one of our partners, the National Association of Chronic Disease Directors, and actually across other partners as well, both NACHO, NACDD, a healthcare intelligence firm called Levitt Partners, is we've been able to do some state partner engagement meetings. These are really meetings, they're statewide meetings. They're conducted, it's really a gathering of all of the key partners in your states that play a critical role in this or have a stake in spreading and sustaining the National Diabetes Prevention Program. They get together for a couple of days. They look at what's going on all the way from the national level down to the state level and the local level. They look at program successes, but ultimately what they do through these meetings is they plan. They develop a state-specific plan for how are we going to do this work in our state, and what our priorities need to be over the next few years, and how are we going to do this across our groups? Who's going to commit to doing what? How are we going to carry this out? So we're kind of gaining momentum with these meetings. So if you look at the map on the right-hand side of the slide, it will show you the states where we've had these meetings to date. We've done them in 19 states. We have another 8 states on the docket for the coming year. So a lot of good work going on through these meetings, and a lot of great results coming out of them. A lot of momentum gained here across the partners. We're also working on coverage. Again, that's one of our, if you remember back to those big overarching goals for the National DPP, this is one of our key goals. I talked a little bit about Medicare, also working with Medicaid, which is a harder nut to crack, as we all know. We have a demonstration project currently going on where we're funding 2 state Medicaid programs. as well as to work very closely with their public health counterparts. And the goal is really to create a pathway for coverage under the state Medicaid program, using their existing authorities within the Medicaid program to obtain coverage for the lifestyle change program under the national DPP. So in Maryland and Oregon, they're both working with their Medicaid managed care organizations or accountable care organizations or equivalents like they have in Oregon to do this, to develop and implement a coverage model. So this is a good example of Medicaid and public health working together because one group can't do it alone. And ultimately, what we learn through Maryland and Oregon will be shared with others who want to go down this road as well. I've already talked about our looming Medicare benefit that will be taking effect in 2018. This just shows a little of the history behind what happened to get us to where we are today, starting with the Centers for Medicare and Medicaid Innovation, testing those innovative models that would either reduce spending without reducing quality or improving quality without reducing cost. And as I mentioned, the YDPP applied and was funded to do this work. They chose to do it around the national DPP and their Y model. It was tested, it was found to be cost savings. We also contributed data to that to make the case. CMS had to undergo an actuarial analysis to essentially show and document that yes, this met those criteria and this program could be expanded nationwide. So that's where we are today. We have been working very closely with CMS throughout the rulemaking process. And if you're following this, you'll know that the first final rule was just published by CMS a couple of weeks ago on November 2nd. There is the link on the slide to be able to access the press release and get to the final rule if you haven't seen it already. CMS will be hosting a webinar on November the 30th to talk more specifically about the final rule and to share additional information as well as answer questions that folks have. So please take advantage of that if you're at all involved in delivering this program. And then finally, I will close with just a few words on marketing and awareness. We know that promotion is so critical to all of this work. We have to be able to get the word out, both to people at risk as well as to healthcare providers and others who have a stake in this. We've done a lot in this area, working with the Ad Council over the past year and a half to design a very large prediabetes awareness national campaign that hopefully you have all seen. We're also working very closely with CBS, the arm of CBS that sponsors their CBS Health Watch and Health Solutions, to create prediabetes messaging, both that's available through a variety of different means, but can also be channeled through doctors' offices and in TVs that are continuous run, continuous loop in doctors' offices. So a lot of really interesting work happening there. Our partnership with the AMA and our call to action around Prevent Diabetes Stat, Screen Test Act Today, call to action to increase screening, testing, and referrals. And all of the other work that we're doing through our website and other things that we're creating to market the program and raise awareness. Here's a couple of snippets from our Ad Council campaign. The goal of this was to reach consumers, people who might be at risk, get them to take the pen and paper risk test that they can do very easily and push them to this website, doihavediabetes.org, to take the risk test and then to follow up with their healthcare provider. This is Prevent Diabetes Stat. If you haven't been to this website, check it out. This is co-branded, co-sponsored by the AMA and the CDC. It's our call to action, has resources available for patients and consumers, for healthcare professionals, as well as employers and insurers. One of the tools coming out of STAT was a provider toolkit on screening, testing, and referring your patients with prediabetes. A variety of different tools, algorithms to help you to do that and do that easily. Our redesigned website for the National DPP. If you haven't been on the website recently, please check it out. A lot of good resources there, including testimonials, both from program providers and participants. If you are an organization that's running a program, we encourage you to go to the website and input your testimonial on how it's working for you, what you've been able to accomplish. Those are key. And then finally, emerging science. We are doing a lot of work not only to look toward the future, but also to study key aspects that are related to our success around the national DPP. We have a study going on around how to engage people creatively using techniques from behavioral economics and from other sources to be able to make it easier to get into the program and to nudge people in a way that encourages them to enroll. We're also looking at retention tools to engage participants long term. The toolkits on the economic side I mentioned previously. So a lot of work also happening there. So I hope, I know I've covered a lot of resources and information over a short period of time, but just wanted to give you a snippet of some of the things going on. I hope some of these things will be useful for you, and encourage you to reach out to us if you have any questions at all about the work we're doing either on the national DPP side or in DSME. So thank you so much.
All right, thank you so much, Pat, for that great presentation. I would like to address that we've had a couple of questions regarding the availability of the slides. All of the slide decks that will be available will be posted on the Midwest Public Health Training Center's website as soon as we have them available, so make sure to check that out after the event. And I know that we are running close on time, but we have had a few questions that have come in. I know some related to coverage and reimbursement pricing that Pat touched on some of those things. But one of the ongoing things that we have, if we can get a couple of thoughts from you, Pat, would be related to the emphasis of weight loss as the outcome for prevention rather than healthy behaviors. So if you could speak a little bit to that, there's been a lot of questions regarding the emphasis on that versus the health behaviors and the lifestyle changes.
Sure, and really the two are connected, right? So the healthcare behaviors are critical. So being able to, the program really emphasizes healthy eating and exercise ultimately to achieve the weight loss. And looking back, as I mentioned, this program really originated from the original DPP research trial. Weight loss, that 5 to 7% weight loss, was key in delaying or preventing the onset of type 2 diabetes. So that weight loss is a key factor there, but certainly the healthy behaviors are critical to achieving that weight loss. The weight loss is just the outcome that we measure.
Thank you very much. And then just as a note, we will be going through with the poll everywhere. We have availability of the questions even that we don't get to that we can share with our presenters, so we may be able to get some additional responses that way. So thank you.